today I wanted to talk a little bit about some of the selected topics in urological safety. And I think the main reason why this matters, aside of course from the fact that patients always come first and we're always trying to keep people safe, is that this is going to become increasingly something that affects the bottom line. So some of the quality measures that are certainly coming into focus for the way that the payments are going to be structured by the third-party payers, Medicare, Medicaid, all of these things are going to factor in to keeping patients safe and to doing quality metrics that are related to safety. And what I wanted to do today was to split the topic up into two broad categories. The first was to talk about general principles of safety and the way that the safety science is being applied to surgery and to urology in particular, and many of you are probably already familiar with this. You might even sit on some of the boards of your hospitals, the practices and committees, and I'd like to hear people's thoughts certainly about this. And then secondly, I wanted to talk about some of the topics that do come up with respect to urological complications and ways to deal with them. And these are specifically topics related to what often comes up on maintenance of certification examinations. So these are the kinds of things that the ABU is specifically interested in. And I tended to stay away from most of the technical complications like nerve injury specific to certain procedures and that kinds of thing because that's actually a pretty broad topic, and I think for a different venue, and I pulled out some of the bigger ones that tend to reappear a lot in our ABU forum. And again, I want to put an emphasis on the maintenance of certification. Full disclosure, I should probably tell you that I have taught the maintenance of certification course at the AUA on this topic. So first off, the general principles of safety. When you think about safety, much of what has happened with safety in surgery and urology over the last 10 years is something that we have borrowed from the aviation industry. And you might be familiar with this. This is a slide that one of my good friends who's a pilot made for me. And he is a former naval aviator for 20 years, and now he flies the corporate jet for a company called Qualcomm, which is based in San Diego. So he's the captain of the Qualcomm fleet. And he and I have talked a lot about this. I've sat in some of the simulators because he has to go regularly for simulator training up in Long Beach. So the point that I wanted to make with this, and point that we make, my friend who's the pilot and I, is that safety was a real problem with the aviation industry, beginning in the 1950s. And on the y-axis, which isn't showing up here, is the number of aircraft that were destroyed in the Navy, and on the x-axis is time. And the big thing that's important is that it starts here, and the Navy recognized that there was a problem, and they started to engineer systems to correct the problem. Because certainly, in a cold-hearted, bottom-line kind of a way, it costs money to lose aircraft. It certainly costs money to lose the aircraft itself, but it also costs money to lose your personnel and all of the money that you've invested, at the United States government and the military have invested in training them. And so they developed systems. And what you'll see repeatedly in the systems that they have developed over the years is the word safety, and engineering systems of safety that were based not only on the mechanics of the aircraft and of landing and flying the aircraft, which is certainly that we see in our particular field in technical innovations. We tend to be very focused on technical innovations, which is fine because that's part of it. But the point that he always makes to me, that I make to folks we talk about safety in surgery, is things like squadron safety and personnel safety, and focusing on, as he says, management of the cockpit and management of the folks who are involved with the cockpit and management of folks that are involved in keeping the plane safe. And he splits it up into two general terms, because that's the way that pilots approach this, that are completely applicable to what we do. The first is crew resource management, it's called, which is sharing of knowledge and best practices, which is what we're doing today in this forum. We're sharing knowledge and best practices. But then Secondly, and I would argue even more importantly, because this is something that we as surgeons, I think, have a hard time overcoming in our culture. It's called threat and error management. And fundamentally, at the baseline of this is the recognition that humans make mistakes, that we make errors, that we get tired, that we have lapses in judgment. And the whole point in building systems that are safe is to start at that principle, to start at that point, and to engineer systems around that, recognizing the fact that we make mistakes. So there are examples about that in everyday life that I'll get to in just a moment. So first off, crew resource management. This is sharing of knowledge and best practices. Yes, we're doing it here today, but on a daily basis, this should always include nursing and ancillary staff. So how many folks, this is what we do in our hospital. We have, first of all, we have a checklist in the pre-op area. So everything has to be gone through in the pre-op area before they'll even roll the patient back. Patient comes back to the room, patient's awake, we do something called a brief. Does anyone in the room, show of hands, do something called a brief in the OR? That's fantastic. Do your hospitals mandate it? Yes. Okay, this is interesting. So we have the brief, and that of course includes your ancillary staff. You have the OR brief, and then afterwards at our hospital, show of hands, how many folks have a formal debrief? Interesting. So not quite as many, but a few. For those of you who don't have debriefs, at least at our hospital, that's where actually the faculty surgeon, so the residents aren't allowed to do this. It's the faculty surgeon with typically the circulating nurse. We go over what happened. Did you do the operation you said you were going to do? Did anything get added on? Specimens added, blood loss, wound class, all these kinds of things that we have to go through. And that's also the point that if something went wrong, that's the time that we're supposed to identify it and come up with an action plan for preventing it from happening again. Morbidity and mortality certainly is something that we do at our hospital. Show of hands, do folks have formal M&Ms in their programs? So again, not everybody, but close to it. And the M&M in our program at least is very traditional in the sense that it's the way that you might all remember from residency training, but we also have specific systems, quality insurance systems, to break down a particular error or morbidity or mortality when it's occurred and to try to figure out in a systems way why it happened. And then communication and action plans are absolutely important. You just can't say, well, something happened, let's move on. You have to say something happened. These are our action plans, 1, 2, 3, for addressing the problem and preventing it from happening again. Threat and error management comes down to recognitions that humans make mistakes. And in that case, you have to build systems to make mistakes. And this is around us in everyday life. Think of ATM machines. When you get cash out of an ATM machine, typically the ATM machine is not going to give you your card back until you've taken the cash. Or wait, you have to take your card out before you get the cash, right? That's because if you're anything like me, I'm going to take the cash and leave my ATM card in the machine without even thinking about it. Right? Human error. That's a system that has been designed specifically to prevent us from doing that. Or you go to the gas station, the gas pump. Usually if there's diesel at the gas station, it's its own pump. Usually it's a different color. Usually there's a big sign that says diesel. It's away from the unleaded. That's because you might not be on your cell phone, you might be thinking, you might be distracted. You might take the diesel pump and put it into your unleaded car. If you have premium unleaded, that's kind of a bummer. And then checklists, of course, is something that we all do, I'm sure, with the OR, and that's what we're supposed to do, is we're supposed to go down the kinds of things, the way the surgery is supposed to run, and to identify potential problems within the surgery that can be prevented. This is a big case. We got an IVC thrombus, we're going to be expecting a lot of blood loss, we have the blood products, that kind of thing at an extreme level, but at an everyday level, it's important right down to the antibiotics. This is called the Swiss cheese model. Show of hands, have people seen this? So some people have seen this. The idea here is that all of the holes in the Swiss cheese have to line up in order for something bad to happen. So that if you start here, something lines up, maybe the error isn't going to occur with that first level, but then if the next 3 levels all line up, something bad is going to occur at the tip of the arrow. And here's an example. This is an example that happened to me. This is a Swiss cheese model in the OR one day. We're doing a robotic prostatectomy. I had a distracted assistant. The first assistant was the resident. The resident was yelling at the speakerphone because another resident was down the ER with a patient. There was a distracted nurse because they were switching out. It was break time. One nurse coming in, the other nurse leaving. You had a distracted surgeon because I was irritated that the residents were shouting at each other across the room on the speakerphone, and we lost a needle. We forgot about it. It was the anastomotic needle. Nobody noticed it at the time. What saved us? Well, that's easy. The checklist did at the end when they were doing the needle count while we were still closing. We figured out, based on the analysis from a great a scrub nurse and a circulating nurse who had come in, we identified which needle was lost, where was it lost. We went right back in with the laparoscopic ports. We found it, we pulled it out, that was it. End of story. So think about those principles as you go through your daily lives. Think about those principles as you are in the OR. Yes, it's a pain. Yes, we don't like getting held up. Yes, we've got 3 different things going on at once. I just want to get the case done and get on to my next thing. But really, think about the times when we've rushed, when things haven't gone right, and think about how those instances have come back to bite us in various ways. And these are the things that are set up to protect us, the checklist. If your hospital doesn't have those systems, I would encourage you to approach hospital leadership or in some way come up with an initiative to prevent them or to initiate them, including at the office level, because we have checklists whenever we do biopsies, cystos, anything in the office, we have to have a checklist. So that's the general principles I just wanted to touch on. Now, specific principles related to specific complications that the ABU likes to ask about and likes urologists to be familiar with. Rhabdomyolysis. This is typically a complication of improper positioning. It's prolonged compression. It causes muscle ischemia, might result in acute renal failure, which is caused by myoglobinuria with tubular obstruction with myoglobin casts. Show of hands, has anyone ever had this happen in one of their patients? I have. Usually we see it with laparoscopic nephrectomies. Is typically what we've seen it before. I don't know what other folks have seen it in. These are the risk factors. They're male, obese, muscular, exaggerated intraoperative position in some way. You might have broken the table like this, patients like that. They're going to have some hypovolemia with intraoperative hypotension. Typically, these have all been described in the literature. Operative time greater than 5 hours, so they're lying in that position for a really long time. That muscle's getting compressed for a really long time. Diabetes, baseline renal insufficiency, and hypertension. All of these things are potential risk factors for these patients. How do they present? These patients are in pain, and they will tell you so after surgery. Anyone else who's seen this will tell you they are in pain out of proportion to what you did to them. They're going to have oliguria. They're going to be very, very dark urine. They're going to have acute renal failure, acute kidney injury, and labs are going to show an elevated creatine kinase and a myoglobinuria. So they're always going to have protein, the myoglobin, in their urine. The treatment's pretty straightforward. You're going to support them with vigorous hydration. That's typically what test questions are going to be looking for. You're going to monitor their renal function, of course. Electrolytes, hyperkalemia, you have to consider that's something else that test questions will look for. You have to think about what happens with AKI, and hyperkalemia might happen with AKI. You're going to monitor them for compartment syndrome, but fasciotomies are actually going to be rarely required in these patients, and if you look at them as a test question, fasciotomy is usually going to be a distractor in the test question. And there's no evidence currently to support the use of urinary alkalinization, which will sometimes come up with some of the reading. Obviously, also within the context of our current medical legal environment, you're probably going to want to consider getting a renal consult as well. Venous thromboembolism. Show of hands, how many folks will routinely use this intraoperatively? Basically prophylaxis for DVTs intraoperatively. So a good number. Of those folks, is it, and you can just sort of nod or shout out, is it hospital mandated? Yeah, it is. Okay, this is very interesting. It's interesting to see how audiences change and the practices also seem to be changing. A year ago I asked this question and there wasn't a single person in the room who was doing this, and none of the hospitals were doing it. There's actually no official AUA guidelines. So I know we often fall back on the AUA guidelines. In this particular case, there's no official statement by the AUA on prophylaxis for DVTs. Recommended resource that I recommend if you don't use it, it's called Up to Date. It's a fantastic resource. It's online. It's continuously updated. My wife's a general pediatrician. She loves the Up to Date for the general pediatrics. And there's prevention of venous thromboembolic disease in surgical patients. That's the specific citation that's typically an up-to-date. And review your hospital's policy. So the show of hands before indicated that there are a lot of folks who are in facilities that already mandate this. You can do it based on their risk, if you like. I mean, the default pathway is it's pretty safe, and you simply just do it in anyone that you might be doing, say, laparoscopy in. But you can calculate the preoperative risk if you have the time and the inclination to do so. I mean, the risk-benefit ratio is such that the risks are low enough that I think it's absolutely fine that if you wanted to do it in most patients, that would be absolutely fine. But if you consider your risk factors, fall back on this up-to-date reference. The risk factors are increasing age, prior thromboembolism, presence of malignancy or obesity, and definitely malignancy is something you're going to want to consider doing it in. We had a patient who underwent a channel TURP earlier this week, metastatic prostate cancer, and not necessarily a high-risk patient except for the cancer, but we did prophylax him. Other risk factors: inherited or acquired hypercoagulable state, and significant medical comorbidities. Heart disease, infection, inflammatory conditions, recent stroke, preoperative sepsis. All of these things are going to be on the up-to-date recommendations. And then you can split it into very low risk, low risk. It's a little bit like the NCCN criteria for prostate cancer. And typically for very low risk and low risk, you can just stick with doing mechanical prophylaxis, intermittent pneumatic compression, which pretty much our hospital mandates every patient gets in the OR. Moderate risk, you can use low molecular weight heparin, low dose, unfractionated sub-Q heparin, or this fancy drug that I've actually never seen anybody really use. Has anybody in the room used that before? Yeah, exactly. What I do is sub-Q unfractionated heparin beginning in the OR. In cystectomies, we all use it. Cystectomies, prostatectomies, nephrectomies, partial nephrectomies, it's safe. You really can use it. And then everybody, because our hospital says so, gets compression, mechanical compression. And then the same thing with high-risk patients. If you stratified them, it's the same thing. So basically, my cutoff is just about everybody, but moderate or high-risk patients, they're definitely going to get the sub-Q heparin in the OR. Air embolism, rare and potentially fatal. It's rare, but the AUA likes to, or the ABU likes to ask this question. Its most common cause is direct placement of the Verus needle or trocar into a vessel when you're first getting access. It's happened. We've seen it happen. It was not on our service. It was on one of the other surgical services a year ago. So it definitely still happens. It might also occur during intraoperative venous bleeding at higher intra-abdominal pressure. So that's important to keep in mind because I've heard of it happening in that context too. See a lot of brisk bleeding from a dorsal vein during a radical prostatectomy. It's going to present with tachycardias and arrhythmias, hypotension, acute decrease in end-tidal CO2, elevated right heart and central venous pressure. Maybe, but at this point with these three factors, I think anesthesia is going to be telling you there's something bad going on with the patient. The textbooks always say this mill-wheel murmur and cyanosis of the head and upper extremities. Boy, I don't know. In the acute setting in the OR, I just don't think you're going to have to worry about it. You can kind of note that the textbooks still say it. So the first question, the first management, and this always comes up, is release the pneumoperitoneum. That's like the first thing you need to do. And you don't often necessarily think that's the first step because a lot of things are happening at once, but it needs to be the very first thing you do. Just release it. Cease the insufflation, obviously, administrate 100% O2. This is a question that they love, left lateral decubitus with the head down to theoretically prevent the air from getting into the pulmonary tree. Aspirate the CO2 bubble with a central venous catheter. These are all things that you can do, and anesthesia might be trying to do that, but most of the time you're just going to be resuscitating folks. And this is important because this has come up. Don't forget that the patient might also be bleeding. So you're trying to sort out what's going on. Is the patient hemorrhaging? Is the patient having air embolism, or do they have both? So lots of things going on all at once, but those two things should be going through your mind. Laparoscopic bowel injury, I mentioned this one because this also pops up a lot on examinations with maintenance of certification. It typically has an atypical post-op presentation after laparoscopy. Usually these patients are not going to have acute abdomens, peritonitis, acute abdomen leukocytosis. You're just generally not going to see it. they're just going to kind of sit there not looking quite right for a day or 2 days or 3 days. Usually they're going to have symptoms within the first couple of days. They will have some distension. They might have some diarrhea, which might throw you off a little bit because, well, their bowel function's returning. They're typically going to have single trocar site pain out of proportion to the exam without any purulence or erythema or indications that they're going to have an infection around that site. The signs, fever, low grade, abdominal distension, leukopenia, they love putting this in test questions. It's actually a decreased white count. It's not going to be an increased white count typically. That has made it into our literature and it has remained there. And then nausea and vomiting. Diagnosis, you typically are going to get a CT scan. Oral contrast at a minimum, most people will recommend triple contrast, oral, IV, and per rectum to see where the injury is. It's got a very high sensitivity and specificity. Delayed images if possible. Remember that you're going to see some intra-abdominal gas for up to 7 days post-op, so that might not be a particularly specific sign. Get a general surgery consult. These days, don't try to manage this on your own. You really, in this medical legal environment, you really need to get your general surgery colleagues in there, even if you think you've got the skills to be able to do it. I strongly recommend they at least bless it. Immediate surgical exploration with bowel repair and or resection. Finally, I'm going to close with prostate biopsy prophylaxis, because this has been an issue that we will touch on again tomorrow in a debate setting. Prostate biopsy, obviously antibiotics are indicated in all patients. The reference is the UA antimicrobial prophylaxis best practice statement. That's what you'll find on the AUA guidelines. The AUA guidelines still say this. They'll say single dose or 1 day regimen only. So you don't have to give them 2 or 3 days of antibiotics, just give them that 1 day. The antibiotic of choice still is fluoroquinolone or a first, second, third generation cephalosporin. I don't know how comfortable you feel, what your practice patterns are in particular, but this is what's still being recommended. Alternatives are Bactrim, aminoglycoside, and aztreonam if they have renal insufficiency. And this is what the statement looks like if you look at it at the AUA guidelines. Exactly what I just said, except up here in these columns. Now, in 2016, the AUA convened a task force because of the infection risks. Show of hands, how many folks have had someone get uroseptic after a transrectal biopsy? Yeah, it's scary. It's really, really scary. 1 or 2 days after you do a transrectal, they're in the ICU, right? And this was something the AUA, of course, noticed. They came out with a prostate needle biopsy complications white paper, which is on the AUA website. And they came up with a whole pathway, specifically if you notice in your practice, and they made it deliberately vague, quote, more infection-related complications. So it's up to each individual practice and each individual provider. These are the kinds of things that get teased out and will often get asked in an exam setting. Infection risk factors or diabetes, all the ones you could imagine. Diabetes, comorbidities, immunosuppression, history of UTI or prostate biopsy infection in the past. Higher cumulative number of biopsies, but not cores. So you can have somebody who's had like 2 or 3 or 4 biopsies negative, or they're on an active surveillance program, you're getting another biopsy. That increases their risk. You do a saturation biopsy, 20, 25, 30 biopsies, or cores, apparently that does not increase the risk. Nobody's ever been able to prove that, to my knowledge, although I know we have a saturation biopsy expert. Infection risk factors, and this does come up, antibiotics in the prior 6 months. So if you're talking to the patient says, I've taken antibiotics for whatever reason the prior 6 months, it is a strong risk factor for getting uroseptic after biopsy. Recent international travel. We have a lot of folks that have been in Southeast Asia. Fluoroquinolone resistant E. coli is endemic in that area. And so tease that out of the history, because we have folks that have had no history of antibiotics, no history of infections. They get uroseptic, they've got E. coli resistant to everything, and we have no idea how it got in their gut, and then we found out that they spent 3 months in Vietnam. The previous year or 2 years. It turns out, because of fish farms, among other things, that it's endemic there. Healthcare worker and colonized with resistant bacteria. There is an algorithm that the white paper has, and I invite you to study it, look at it if you're not familiar with it. It's something to go down and follow if you are noticing increased episodes of urosepsis in your practice. Some of the more key points are you check your sterilization protocols, consider iodine enema and or needle cleansing, refer to your local antibiogram, work with your infectious disease colleagues, and assess the infection risk factors along the lines of what we just discussed. You can also consider transperineal biopsy, rectal culture, and antibiotic augmentation. Rectal culture started to fall a little bit out of favor. The last couple of years, there have been some data to suggest it's not all that reliable, but certainly it's still in the algorithm. If you augment your antibiotics, you're supposed to give a fluoroquinolone plus a first, second, third generation cephalosporin, or fluoroquinolone plus aminoglycoside, or fluoroquinolone plus amikacin, fosfomycin, and or ID consult.